and walk and before the evening dinner. So welcome to this evening symposium on luminal gas detection, a novel approach to aid diagnosis and personalization of therapy in gastrointestinal disorders. I'm honored to co-chair with Jutta Keller, professor from Hamburg, Germany. And we really have some three outstanding speakers, one of whom was not able to reach us live, but will give us a kind of a video call and a recorded demonstration. So with that as a brief, I know Mark is also at the back. That is great. I know, Mark, we wanted to start a little early with your permission. So, and I think the first talk is entitled The Gas Capsule, Development of a New Potentially Disruptive Technology, and who better than a co-founder and one of the chief principal officers who is directing the clinical trials globally, Kyle Berrien from Melbourne. Kyle, welcome to Ascona 3.
Thanks very much, Satish, and thanks, Jutta, for chairing this session, and thanks, Mark, for putting on such a great conference and allowing us to be part of it. You know, we are a small stage company out of Australia, and, you know, big disclaimer, I'm one of the co-inventors of the device. I am a co-founder of the company, so I do have shares within it. Another big disclaimer is I am an engineer and a scientist, and I do not understand anything that you guys are talking about. But I'd really enjoy being here. So, you know, it's only through meeting you guys and talking to you guys that we can make devices like this better and enable you guys to actually have actionable results to help your patients. So just really briefly, you know, we're a small stage startup out of Australia. We have an office in the US now. We originally came out of a university IP where I ran the first in-human trials in the university, and we are looking to commercialize what is the first ingestible capsule that looks at the metabolic output of the microbiota regionally through your GI tract. So we're initially targeting a motility indication or the measurement of transit time as a replacement for the smart pill, as you would have heard yesterday. But in parallel, we're looking to expand beyond this indication into things like small intestinal bacterial overgrowth and really harness the power of what our device can do. So this is our system as a whole. It's a similar sort of design or setup to the smart pill. We have the capsule itself that wirelessly transmits to the receiver that's worn on the body. You have a standardized meal. This meal does not come with any beetles, unlike the Medtronic one does. This is all of the patient-facing interaction. Now, we have a mobile device or a tablet that lives in the clinic, and this is meant to replace the computer and the docking station of the smart pill. It helps set up the patient, and then it receives the data at the end and transfers it all to the cloud, where you'll be interacting with this clinician's portal. And this portal is where you'll do all of your assessments. So the actual capsule itself has been a long time in development, and it contains numerous different gas sensors. So it's a similar size and weight to the smart pill. It's a little bit cleaner looking, doesn't have any of that fishtail or the ridge of the smart pill if you've ever seen it. It's got two different gas sensors. It's got a relative humidity sensor and temperature sensor. It's got a accelerometer and what's called a directional coupler. It's a little bit physics heavy. I'll get on to why these things are important in a second. But the output of our devices will give you hydrogen and carbon dioxide concentration, as well as an indicator of anaerobicity. So our volatile organic compound sensor is highly sensitive to a decrease in oxygen. We give you an accumulation of the capsule orientation change, or the tumble, and I'll talk through that in a minute, and also this efficiency of the antenna output. Total operational lifetime of our device is greater than 10 days. Testing shows it's about 14 days. 4 days of that is full gas sensing capability, and then we roll over into this temperature-only mode to kind of get through to excretion. So our first product that we're going out with is a transit assessment device. The indication for use is the exact same as the smart pill, so we measure whole and regional gut transit, and we do so with the sensors that I've just mentioned. So this is our regular traces, trace output. So these are the traces that you'll be interacting with to make these transit assessments. So whilst it's quite a complex set of graphs, there is, it's all should be laid out in a pretty easily to understand way, and we have a wizard that will talk you through how to interpret it. So up the top here, this is a temperature sensor. So this, rise at ingestion and fall at excretion. I think that's pretty uncontroversial. This pink trace here, this is our anaerobicity indicator. So this one gives you a big change as it goes from the small bowel into the colon. And so this actually is quite consistent in all of our traces, no matter what the indication that we've looked at so far. So an IBS patient, SIBO patients, ulcerative colitis, and healthies, people with gastroparesis, people with slow transit constipation, all have the very large change in anaerobicity going from the small bowel into the colon, but the way that it presents itself does differ. This green trace here, this is our carbon dioxide trace. This is primarily used here as a measurement for gastric emptying time. So hydrochloric acid comes out of the stomach, mixes with bicarbonate. That chemical reaction creates carbon dioxide, which we see. We'll go through that in a little bit more detail. And in the colon, you can see a lot of carbon dioxide being created through microbial metabolism. This purple trace here, this is our hydrogen sensor. This hydrogen sensor does have a limitation of 1% hydrogen before it will start to show, but you can see a large amount of hydrogen being created in the colon. This bottom graph here, this is, we're calling these our secondary markers, and these are really only used as backup for the primary indicators. So we have humidity, not really that important. It gives you a backup for ingestion. This is that capsule tumble indicator. Now this one is from our accelerometer. Now I don't really care in our capsule about acceleration. We don't measure acceleration, we don't measure movement, we don't measure spin, but what we do measure is the change in the long axes as it's going through the GI tract. Now why we're doing that is just to try to understand when it has these major changes in the way that it's transiting. So in the stomach, it's sitting in the antrum, bouncing about a little bit. We've got a lot of ultrasound of this, and moves towards the pylorus, jumps back. It will flip over every now and then, and you will get some sort of movement up front here whilst it's in the stomach. But as it starts to journey through the small bowel, that tortuous path will actually cause this long axis change to start to accumulate. And you can see here that it does, and it lines up quite well with the carbon dioxide and then with our antenna efficiency. So this bottom graph here, this is what's our antenna efficiency. So this is looking at the electromagnetic properties of the tissue that is surrounding the capsule. We have not delved into what this actually means physiologically, but what we do see is major differences between the different regions. So in the stomach, it's very common to see a rise and then a fall at gastric emptying. In the small bowel, you get quite a noisy signal, and then as it goes through the colon, it becomes somewhat erratic. So we're just starting to unpack what these things mean. So as you're going through our wizard, marking out gastroduodenal junction, we have algorithms that will automatically guide you to where you're meant to be. But what we're telling you here in the guidance on the left is that you mark it at a step increase or a spike of carbon dioxide. So that's a spike of carbon dioxide in this green graph here. But there's a couple other features of carbon dioxide there. So we use these secondary markers here. So if unclear, select one coinciding with a steep increase in capsule tumble or a sudden change in antenna reflectance. So you can see here the capsule tumble starts to increase at the time, and the antenna reflectance changes from a somewhat smooth signal in the stomach into a noisier signal into the small bowel. So it's really about the coincidence of all of these measurements that gives us confidence that we are measuring gastric emptying, and we have data that Peter will be presenting of how we compare to the predicate device. So marking out the ileocecal junction, again, this is done through a volatile organic compound sensor that has a large reaction to a decrease in oxygen. Here is another indication of this flat, no oxygen change within the small bowel, and then a huge change as you go into the colon. Again, carbon dioxide created, hydrogen created, changes on the antenna reflectance. And so we have some guidance here that will help step you through that. So marking out, obviously, ingestion, gastric emptying, ileocecal junction, and body exit, you get all of your regional transit metrics. And so our first device is based around the creation of these transit metrics. So we are using the same ranges or same thresholds as the smart pill for now. We will be looking to expand through clinical trials to evaluate what our own thresholds are going to be. But again, what we're showing here, what we're using our sensors for is a very primitive view of the gastrointestinal tract. It's just about, we're trying to segment it, this region, that region, then into the colon. And it's just, there's much more data here than we're actually looking at right now. And, Peter is going to talk about what we have been looking at within, some of our gas outputs. But you can see that, carbon dioxide and hydrogen created in the colon, this is quite interesting data that never seen before. What's actually happening in the small bowel, this is actually really interesting. And Gerald Holtman has a video about what we've been seeing in the small bowel. But within these other sensors, there is some really interesting results that we have really not started to explore yet. So, we're really looking at how can we really understand our data and build all of our data sets out. So we've been involved in several different clinical trials to date. We've done over 700 ingestions. We are still pre-market. We start our pivotal trial for FDA clearance early next month. First participant is expected into that trial. But you can see it takes a whole host of trials for us to get to this stage, and that is just within this motility area. So the next area that we've been looking at in parallel is all around small intestinal bacterial overgrowth. This is more complicated because what is our gold standard? How are we comparing ourselves? It's a very difficult spot to work, and we've got some really interesting early stage results there. But a lot of people have actually come to us and wanted to use us within other trials. So we are really open to working and partnering, collaborating with research that is really interesting. So, we've worked in irritable bowel syndrome and IBD. We've assessed dietary interventions, whether it's kiwi fruit, whether it's mixed fibers, or whether it's a specific fiber for different types of bread. So this is what I'm actually really excited about. So yes, we have our two core pillars that we are progressing, but if you do have anything that you find interesting or you want to use us for, or you'd like to collaborate with us, do feel free to come up and talk to me, because we are really, really interested in working with stellar researchers such as what's in the room. So transit assessment first, but we're not going to stop there. We are a small company, but we are working on all fronts to progress this and move forward. So thank you, guys.
Yes, please. Yeah, here it is.
Thank you very much, Asbjørn Drews from Denmark. We look very much forward to using your capsule. I was just wondering, is it MRI compatible? Because that's often an issue that we are struggling with.
Yeah, no, it won't be MRI compatible. Unfortunately, there's a lot of metallic components within it, so electronic components, a bit dangerous in an MRI.
Probably not dangerous, but just kaput.
Yeah.
Hello, Dr. Helen Schaffelberger from Lugano. From the capsule endoscope, the given imaging, we know that it's sort of like a wash machine in the small intestine. The capsule goes forth and back and forth and back. Aren't you worried not knowing this and integrate it in metabolic data?
Yeah, so a really good question. Again, I'm not a physiologist, I'm not a gastroenterologist, I'm an engineer, but maybe Peter might be able to answer something like that.
Well, at the moment we can tell where it is in the like small intestine, large intestine, or stomach. But within those regions, that's been the big problem with a lot of the with all the capsule mechanisms. And there are ways that it can be approached, and they haven't been explored as yet. So, like magnetic beads and all those sorts of ways. So this is going to, once that can be done, it's going to make it just a miracle tool for looking at, instead of just a small intestine, looking at the true differences between the jejunum and the ileum, and in the colon, as you know, it's more than one organ really. So these are really important issues.
So Kyle, quick question. I know you have both the CO2 and the hydrogen sensor, two gas sensors in there. Mm-hmm. How is this CO2 sensor helpful in either transit measurements or maybe in the future for SIBO assessment?
Well, yeah, I mean, that's a really good question. So within transit, it's quite easy. So carbon dioxide is the chemical reaction from bicarbonate and hydrochloric acid. So the creation of carbon dioxide is what our primary measure is for understanding when we've come out of the stomach. Now, carbon dioxide is a metabolic output from the microbiota, and so it should tell us a lot of information about what's happening as you go through, because not everything creates hydrogen, but most of it does create carbon dioxide. So we do see a lot of value within this sensor.
A quick question along the same lines. Do you already know what happens if your patients or the subjects who swallow the capsule take PPIs?
Yeah, so PPIs are excluded from our groups because it does reduce that hydrochloric acid. So just like the smart pill, the use of PPIs is discouraged. We have tested it only on a small scale.
And antibiotics?
Well, antibiotics, that's a...
I guess the rules are going to be a bit like doing a breath test, aren't they? I imagine.
Yeah, well, once you get to small intestinal bacterial overgrowth, likely there'll be a whole host of other things that we'll have to exclude. But right now, for transit assessment, it shouldn't really affect it.
But I think that may be a good point worth considering, because I think PPIs is really good. But for smart pill, we don't exclude antibiotics at the present. I mean, there's no reason to exclude it because those cells are not affected. But I'm just thinking aloud, I mean, really, amongst friends here, really. Yeah. Would that be something we should be thinking about? Peter?
It really depends upon what you're looking for, because it's got so many capabilities and potential capabilities that some of them won't matter and some it may matter. But we haven't had a chance to do subgroup analysis, and of course at present time, everyone who gets the capsule is not on a PPI and is not taking antibiotics within the last 4 weeks, or probiotics or anything else that might possibly change motility and so on.
So is it for our clinical trial the same? No antibiotics for 4 weeks? I don't know. I'm just asking.
No, not for the pivotal trial. Is not the same. No, we don't foresee it being a problem for our pivotal trial.
So the only thing maybe if, I know the trial is already started or about to start, maybe worth noting if people are using it, because that may be something you may want to consider post-hoc analysis, because that could be an important
Yeah.
variable that may confound the results of your study, right?
That's a really good point. We'll add it into our case report form.
But also kind of a serendipitous subgroup analysis enabling kind of event, because some people will surely be doing these things.
Oh, absolutely, yeah, for sure. You know, a lot of really interesting findings are just observations that we've had running it for the first time in humans, and you know, we haven't seen these things before. So.
Yeah. And I'm just curious about this antenna reflectance. Does it have something to do with conductivity? Is it something similar?
So it's very similar. So it's the electromagnetic permittivity of the surrounding environment of the capsule. So it's the way how the impedance of the environment for electromagnetic waves. And so when you're talking about the efficiency of an antenna radiating, it's all about matching impedances of that antenna to the surrounding environment. And so as you're going through the GI tract, you're getting mismatches of impedance every now and then. And you see that here with these changes. So these are changes in impedance of the surrounding environment. Could that be more liquid? Could it be more tissue? Could it be a change in tissue? I have no answers about that. You know, is this noisy pattern here, is this something to do with peristalsis? No answers about that. Right now we're using it as a very crude measure. We have the ability, and I do want to run a subset study of sampling this more frequently to try to understand if we can get more data out of it.
Okay, thank you, Kyle.
Thank you.
In the next talk, we are going to hear more about potential application of gas capsule in clinical practice. And I'm honored to welcome Peter Gibson from Monash University, Melbourne. I do not need to introduce him to you, but Peter, is it correct if I call you the scientific father of the gas capsule? Oh, so...
I've helped the engineers understand the biology and the gastroenterology. I also helped Kyle understand the electromagnetic properties around that. No, I didn't do that at all. It does require a lot of skills in various areas. Okay, now what I mean, basically the Atomo gas sensing capsule is treading in new territory, and this is important to realise because we're trying to open up black boxes in the gastrointestinal tract, just as the pill cam opened up the small bowel to many new bits of information we didn't know. It's got huge value in research. That's why I got involved. It was right down our line. We really wanted this. And it can examine GI physiology in the ambulant human without having to manipulate their gut. It can interrogate the microbiome, not the actual players, the postage stamps, but the goods and services that the microbiota are providing. So in the soluble milieu. And the really good thing is that it's safe and patient friendly, and just like the smart pill, it's very good in that it can be repeated, no radiation, and so we've got the chance of real-time data as well as longitudinal data, which other techniques have difficulty in providing. Now, the potential indications, clinical applications is what I'm going to just touch on here. Unequivocally, regional transit time measurement seems a no-brainer, and hopefully that one is almost ready for prime time. But in the speculative side, I'll talk about something in the stomach and colon, and Gerald Holtman will talk about the small intestine. Now, in terms of regional gastrointestinal transit times, really what we, as we talked about in discussion before, what we really needed to do was to make sure that we were accurate in our landmarks. Entry, exit, easy, gastroduodenal junction and ileocecal junction, and we don't have abilities to get landmarks in between those at the present time. And the methodology we decided to do was to test like with like, and so we have done tandem ingestion where patients will ingest, or volunteers will ingest one capsule and then the other one in a random way at the same occasion, and there's been no issues about using swallowing 2 capsules. The study we did in healthy controls was to do a tandem Atmo capsule where they took 2 Atmo capsules because we wanted to define what the biological variation was, because we don't have that information from the smart pill within an individual. We also did a tandem smart pill capsule Atmo capsule studies to compare the landmarks from both of them. And to do this, we did a primary cohort of 26 subjects and then did a validation cohort, which was done not only in Melbourne, but also in New Zealand with Richard Geary in Christchurch. And the idea was was to compare within individuals the major landmarks being the gastroduodenal junction as we believed that we were measuring it, as opposed to the smart pill, and the same for the ileocecal junction. Now, this is sort of a view, an overview of the differences. So these are the differences between the two, and of course this is a bit of naughtiness putting this up because the scale is fairly large for the gastric emptying time. It looks like it's perfect, but in fact I'll show you more data. But you can see that they really are measuring a very similar thing. And if you look at the Atmo cohort, the variation we see between 2 capsules, which by the time it gets down into the colon is they're starting to move apart a bit, is very, very similar to when we do with the smart pill and the other. So if you look at the correlations between these, which is what it's pretty easy to see for both that the correlation is very good between the times we get for these landmarks. And of course, doing the appropriate way is to do a Bland-Altman analysis. And you can see the most important features here are, firstly, that the bias, this here, is very, very minimal. So it's almost when you average them out, or the median, whichever way we do it, it's very similar. And that the scatter you see here in the limits of agreement are very much the same as there's the 2 of the capsules in the one person at the same time. And if you look, the smart pill data on this is similar, very similar when the smart pill has been swallowed today and then in 7 days or 2 weeks or something. This is the sort of variation you get. So we were very pleased with this. And in the ileocecal junction, very similarly, where there is minimal bias and the limits of agreement are very similar between the primary cohort, validation cohort, and the Atmo cohort. Now, we've also done through a group in Sydney and ourselves, we've looked at 43 symptomatic patients who had a label of, a diagnosis of gastroparesis or chronic constipation, and just a look at this. This was presented at DDW in a poster, and the times are very, very similar. No significant difference between the times you see. The diagnostic agreement, the smart pill identified 6 out of 32 patients with delayed gastric emptying and 14 out of 34 with delayed colonic transit, but the correspondence was 83% and 79% agreeing with the Atmo capsule. And I can tell you that you might say, well, that's not very good, but some of them were just on each side of the cutoff. And so it doesn't really, it's not really the best way of looking at that to evaluate it. And the same thing here is that the bias, the difference between the 2 capsules is very, very small, so that we believe that the results are valid. So our conclusions from our transit studies in healthy subjects is that there's a moderate biological variance in capsule measured transit times within any individual, which we've defined, that the landmark assessment is accurate compared with the FDA approved gold standard, and that the differences in transit time between the Atomo and Smart Pill in the primary and the demographically different validation cohorts has no differences. In our first look at patients with presumed motility disturbances, there's adequate agreement in transit times and good diagnostic agreement. So a well-powered study, as Kyle had mentioned, is about to start in USA and Australia, and hopefully that will come through pretty quickly and give us the information that where it can then be launched into practice. Now, one of the observations we made, which we weren't looking for, but was in the stomach, we saw these bursts of CO2 in some people. And in trying to work out what this meant, that we know that CO2 in the stomach is a chemical reaction. It's not from bacterial respiration, and it's a bicarbonate and hydrogen giving carbon dioxide. And these bursts, we believe, will be reflecting hydrogen and bicarbonate meeting, and our hypothesis is that these bursts we see are actually measuring duodenal gastric reflux. And let me show you what I'm talking about here. Here's a healthy. This is one of the healthy subjects, and these boxes here are where the gastroduodenal junction is according to our criteria, and you can see that the CO2 is usually pretty flat. There's not deviations, but we got patients like this where there was this big jump here and a big jump there, where those arrows are. Here's a big jump, another. Well, there was two big jumps, and here there's 1, 2, 3, 4 big jumps. And these were gastroparetic patients, but this was a healthy subject. We can quantify these by looking at area under the curve using some modelling type techniques, and this is our attempt to quantify this. Is that the normalised area under the curve of these bursts are shown on the y-axis here, and patients with functional dyspepsia with gastroparesis and the healthies are shown here. And you can see that it was the gastroparesis patients where it was predominantly present, but it wasn't the diagnosis that dictated these. It was delayed gastric emptying time, and here's a delayed gastric emptying time, and all the ones in that's where the majority of these things were. So this was a very interesting observation, and my take on this is that it's that we can quantify this, that we believe, that we speculate that it represents duodenal gastric reflux, and it offers potential to evaluate the frequency and magnitude of this occurring. We have no other way of doing this. Other techniques that have been attempted have been very poor, and that what excites me is that if this is believed to be important in some conditions, we can quantify changes in this. But that was an incidental finding. Now, colonic carbohydrate fermentation is my very big interest, and this is where I was very excited by the capsule and hydrogen concentrations in the colon only come from fermentation of bacteria and of carbohydrates by bacteria, and what the concentrations represent is a balance of the production versus the disposal of hydrogen. So which is disposed by absorption, acetogenesis, sulfate reduction, methanogenesis, and fumarate reduction, which is actually much bigger than what recently been shown to be more important than some of the others. And the relative constant, so what the hydrogen concentrations do not tell you how much production, how much fermentation is occurring. But if you look along the bowel, we would assume that the same disposal mechanisms would be occurring along the bowel at one particular time point. And so we can look at the relative concentrations in different segments. We would propose that will tell you where the carbohydrate fermentation is occurring. Now, why on earth would we be interested in this? Well, carbohydrate fermentation plays a pivotal role in maintaining colonic health. That if you have excessive proximal fermentation, there's now increasing information just tells that this induces epithelial injury, can induce mast cell inflammation and visceral hypersensitivity. And this is the basis for perhaps the reducing FODMAPs having changed in the natural history of IBS. And if you want someone to have lots of fermentation in their bowel, give them lots of readily fermentable things, you'll get a massive amount in the proximal colon and less in the distal. But deficient distal fermentation is the one that is associated with the adenoma carcinoma sequence in suppressing it, and is also anti-inflammatory and mostly shown in animal models, but very convincingly so. So to get the correct proximal distal imbalance, proximal distal imbalance occurs in many situations, and what we have shown in the last century and have recently shown, Robin Spiller has recently shown it with the MRI studies, and we've shown it here with this, as I'll show you, that if you want to get the fermentation pushed right around the bowel so you get even delivery of short-chain fatty acids all across the bowel, then you need to combine a poorly fermented fibre to push the fermentation of a readily fermentable fibre distally. And this was this has been well shown, although it's not really in the consciousness of gastroenterologists, unfortunately. The thing is that we have no way whatsoever in any other way of telling where the fermentation, whether there's more distal fermentation, whether there's deficient distal fermentation. Short-chain fatty acid measurement is not the way to do that, as I pointed out in my talk and hopefully convinced you for those of you who were there. So this was the potential to do this, and this was just a summary of a study done by Dan So, a dietitian who was doing his PhD. And what we were doing was giving patients with IBS, we were feeding them all their food, low FODMAP diet, and then adding with the good quantity of fibre, normal fibre intake, but we're adding sugarcane bagasse, which is non-fermentable fibre, and a resistant starch, a high amylose starch, which is readily fermentable. And so they got either no supplemental fibre, the non-fermentable, or both. And what we did was to divide up arbitrarily in the colon with the transit with the curves into 4 segments. Now this is not the way it is. It's not like the middle segments are they're all even segments. But we know that the first segment is the proximal bowel, and the 4th segment is the distal bowel. There's no doubt about that. So if you look at the results, and I can only just show you one thing here, and this is looking at the median of the regional colonic pH. Because pH, we were told that pH can do all this. You don't need to do hydrogen concentrations, and in fact, the pH for the combination was no different right across the bowel. These are across the segment. So the ratio of the first quadrant to the 4th quadrant was no difference, and it rose as we know it does. Now, but when we looked at the regional colonic fermentation using the Atomo capsule by the hydrogen concentrations, you can see first of all on the non-supplemented diet that it was down. It was lower in the distal colon, and it's not always that way in people, but in these patients with IBS it was, and the sugarcane bagasse did not change things at all. I think that's one sugarcane. The colour's not coming up that well, but But in the one where we knew we were pushing the fermentation distally, we could actually find it. So what this told us, it was fantastic, and it excited me because we have a method of looking at regional fermentation, and the Atomo capsule is responsive to change. And the other way we've looked at it is to put, we have 10 poor Australian healthy volunteers who took exclusive enteral nutrition for 3 weeks and nothing else. And one of them actually loved it. But the regional transit times, you can see here that if you look at just the colonic transit time, the EEN prolonged the transit and the regional colonic concentrations really crashed. And that's exactly what you expect to see. And so this is it's a nice demonstration that what we expect to see is what we're seeing with the capsule and these two things there. So other observations we've made is that if the first quadrant has higher concentration than the fourth quadrant, that is potentially less favourable for gut health. Certainly is in rats and pigs, and that occurred in about nearly half of the healthy volunteers we saw. The other thing is that the habitual diet, the patterns that we got when we did it at different times were the same. So it wasn't like breath tests where you might get fructose malabsorption today and then 35% of times you won't get it next time you do it. This one, we got the same results each time. Now, so the conclusion is that it's a reliable indicator of an individual's pattern. It varies across individuals as it's responsive to change. Now, just my last thing is the example of the clinical value of the Atomo capsule is here. This is just a bit of theorising here. That you do an Atomo capsule study, you show colonic transit, so you would treat with poorly fermented fibre to hasten transit, which is the effective way of doing it, and you would then repeat with the Atomo capsule to see if you've been effective. If you then alternatively show that you have reduced distal colonic carbohydrate fermentation, you would use both of them, and you should then be able to show that you have improved the profile across the bowel. So this is just a very, very crude sort of an example of how it can be personalised in that we're measuring physiology and we're using fibres appropriately. And I can think of many other examples of how we could do that. So in conclusion, I think it's got lots of potential, and I think the applications of this tool is limited only by our imagination. Thanks.
Thanks a lot, Peter, for a wonderful talk showing that we can maybe not only detect something we can show with other methods too, but have completely new applications. There are questions from the floor, and we can take one or two questions to still be in time.
Not sure if that's working, but I'll just yell. I was quite interested in the gastroparesis work with the carbon dioxide spike, because we've spent a large amount of clinical careers focusing on the pylorus. Do you think that suggests that this could be retrograde activity from the duodenum in these patients?
Forgive us, I think we might have missed your question.
I said we've spent lots of our careers focusing on the pylorus in gastroparesis, which in many situations proved very unsuccessful. Do you think what we're seeing here with these spikes in CO2 is retrograde activity from the duodenum? And is this a disorder of the duodenum and not the stomach? Do we need to change the name?
Oh, well, that's a potential, and all we've done is shown what we've found, and we've only just analysed this, and now we've got to put our thinking caps on of how we can actually address that, because this is just an example of an incidental finding that might have significance in understanding symptoms.
But these were healthy controls, so this is not an
No. These were people. There were 7 healthy controls, and there were about 30 or so people who had motility.
But you found this in healthy controls as well?
Yeah, but a little bit.
Okay.
Only a little bit. So we know the duodenogastro reflux occurs in healthy as well sometimes. So, but what excited me was that we can quantify it with this technique.
Was it associated with symptoms?
Symptoms, we thought so, but many of these patients were symptomatic. It was really hard to sort out where the symptoms were being aggravated. There was one patient where it was clear that they pressed the symptom button when this occurred, but it wasn't a consistent feature.
Yeah, when you first showed these results, I was didn't understand, because you showed that you used the CO2 peak to define gastric emptying, but from your pictures I had the impression you always use the last CO2 peak to define gastric emptying, and if there are further several ones, it's reflux.
Yes, yep. but it also that's where, if there is a confusion with these other peaks, that's where the
secondary markers.
And
that's why we have these backup sensors to make sure that we are actually measuring what we think we're measuring.
And I would say that all of the where we're comparing landmarks with the smart pill were all done blinded to the other. There wasn't any manipulation of which, when you're first doing it, you might say, well, what's this? And that's why those markers were put in to try to differentiate these things.
It makes all the difference. I saw the results of an original version, and it was, really not clear where the gas was being produced, but this looks quite convincing now. Yeah.
So, are there any more questions from the floor? No, if that's not the case, we are very curious where your imagination will lead us, and what else we can find out using this capsule. Mm-hmm. Yeah. And I'd like to introduce.
Hello, I'm Gerald Holtman.
Stop, Gerald. Stop.
Yeah. Gerald Holtman. He originally was from Germany, and he worked at Essen University in the GI unit when I finished my studies at Essen University. So I know him for really quite a long time, more than 30 years by now. And it was a fascinating characteristic that he was always able to pick up the most promising new developments. So I'm very I'd like to see what he can tell us about cyber. Those of you, cyber detection, those of you who have joined the talks yesterday will have heard that there are lots of discussions. I believe in glucose breath testing, and as far as I've understood, Satish does so too, but it has its disadvantages, and maybe they can be overcome by new technologies. So now he can start.
Hello, I'm Gerald Holtman. And I'm delighted to have an opportunity to share with you some of the data we have generated in recent times with the Atomo system. My presentation is entitled The Gas Capsule and Small Intestinal Bacterial Overgrowth Initial Data. And you may ask the question, why is this topic important? And the importance is very simple to explain. Ultimately, the surface of the small intestine with all the mucosal folds, villi and microvilli approaches 200 square meters. And this is roughly the size of a tennis court. Therefore, the surface of the small intestine is at least tenfold greater than the surface of the colon. And a lot of our microbial work is currently focusing on colonic microbiome, and it's probably time to look at the small intestine. Indeed, if we look at the literature, and these are a couple of systematic reviews and meta-analysis that we have done in recent times, there's good evidence that small intestinal bacterial overgrowth or dysbiosis is linked to a variety of GI and non-GI diseases, including irritable bowel syndrome, functional dyspepsia, liver disease, and other conditions. And if you go more mechanistic towards the association between dysbiosis and symptoms, here's a study which we published not that long ago in Gut. And what we were able to demonstrate if you measure bacterial density with a molecular technique, namely the ratio between 16 RNA beta and beta-actin, then you find an inverse relationship between the impairment of meal-related quality of life and the bacterial density, and a positive relationship between meal-related symptoms and bacterial density. This is an association, but the question might be asked, does treatment targeting the small intestinal microbiome change symptoms, meal-related symptoms? And this is a study which actually looked at the effect of a non-absorbable antibiotic rifaximin in a cohort of patients who had either functional dyspepsia or a combination of functional dyspepsia and IBS. While there was no difference between functional dyspepsia and IBS, it's interesting to note that the symptom response to a standardized nutrient challenge was significantly reduced in subjects with and without a positive GBT. Now let's have a quick look at the established diagnostic criteria for SIBO. We have the traditional approaches, and many of you know about the direct tests like proximal small bowel aspirate and culture, and there are indirect tests which use glucose or lactulose as a substrate. And SIBO is defined as a presence of the excesses or abnormal type of bacteria in the small bowel. And the problem here is that some of the bacteria have features of oropharyngeal or colonic type bacteria. We do have diagnostic criteria like cutoffs for bacterial counts. If we culture the small bowel aspirate, and the established threshold is 10/5 colony forming units. More recently, it was felt that 10/3 colony forming units is more appropriate because the old 10/5 was based on mechanical obstruction and surgical cohorts. And this is the technical approach. You do an endoscopy or a tube, you aspirate material, culture it. The problem here is that only 20% of microbes which we can aspirate actually grow via the traditional methods. Therefore, it will underrepresent the number of bacteria which we have in the gut. And then there is a problem of standardization. Where do you aspirate? Some would aspirate while you do endoscopy, and you may reach the second or third part of the duodenum, while others would insist that you need to have an aspiration tube which you advance into the jejunum. There is the already mentioned diagnostic cutoff of 10/5 or 10/3, and we may have false negative or positive due to contamination by oral flora, or that you don't aspirate from the right side. And then we have the breast tests. And these breast tests are based upon the fact that human cells are not able to produce hydrogen or methane. Therefore, if we can detect hydrogen or methane in the breast, this indicates that carbohydrates from the gut are being digested by bacteria. Therefore, we can say, so far, so good. We have non-invasive tests. We have invasive tests. They have some limitations. But how good or how bad are the indirect tests? This is work from our colleague Uday Ghoshal, who looked at the sensitivity and specificity of glucose breast test or lactulose breast test. And the sensitivity of the glucose breast test is around about 50%. And the specificity is slightly higher with 83. Sensitivity, if you use a lactulose breast test, is only 42, while the specificity is around about 71. Therefore, some would argue that glucose breast tests are more appropriate, but they only pick up 50% of the infected subjects. In the clinical setting, therefore, direct tests are not optimal, and indirect tests clearly have limitations with regard to sensitivity and specificity. And then on the other hand, there are molecular techniques like qPCR or microbial community profiling or sequencing. But I think it's fair to say that they are not ready for prime time since they are mostly used in clinical studies and are under development. Therefore, if it comes to diagnosing small intestinal dysbiosis or SIBO, we have a burning platform and something needs to be done. And therefore, from our perspective, what needs to be done is test new methodologies to diagnose SIBO and small intestinal dysbiosis. And in this context, we were very excited to test the Atmos capsule. And on the other hand, it's not only a question to define and identify the capability of this instrument to identify dysbiosis or SIBO, but to define thresholds that predict response to therapy. You will have seen this slide or similar slides before. This is a capsule in the bowel. It's a small capsule which most patients can ingest without any problems. And in our study, we tried to assess the association between the so-called microbial metabolic activity, which is a parameter derived or measured by this capsule, and correlates this with established SIBO diagnostic criteria. And we used for this duodenal aspirate and culture and the glucose breath test. In addition, we aim to determine the link between the response to antimicrobial therapy and the intraluminal metabolic activity. This study is currently being conducted at the Princess Alexandra Hospital in Queensland and by the Sanjay Gandhi Postgraduate Institute in Lucknow in India. What are our inclusion and exclusion criteria? We try to have very broad inclusion criteria. Therefore, these are patients with chronic, relapsing, unexplained upper gastrointestinal symptoms. All patients needed to have chronic symptoms, ultimately fulfilling the criteria of Rome 4. All patients were required to give informed consent, and we had a list of exclusion criteria in relation to potential organic diseases. And this is our study design. There are 3 time points which are relevant. We have the time point before endoscopy, during endoscopy, and after endoscopy. Prior to endoscopy, our study subjects completed the Satish questionnaire. This is a broad symptom questionnaire that measures the impact of symptoms, specific symptoms on daily life. It captures 6 extraintestinal symptoms and has some open questions. In all subjects, baseline breath samples were taken and measured prior to the procedure. During the procedure, we aspirated a material from the second part of the duodenum and took biopsies for qPCR. In addition, glucose was injected into the duodenum and the stomach to ensure that substrate was present, and the patient swallowed the capsule immediately prior to the procedure. And if we saw the capsule still in the stomach, we moved the capsule endoscopically into the duodenum. And after the endoscopy, the patient completed the glucose breath test before they went home. And after this procedure, at least for all Brisbane patients, they were randomized either to active medication with placebo or rifaximin, regardless of any SIBO testing. A quick look at the interpretation. The key sensor is the temperature thermal conductivity detector, or TCD, and this generates some data in relation to the concentration of CO2, hydrogen, and methane. And you could have theoretically a stable TCD signal. You can see an increase or what we label a gradient or an area under the curve, and the different types are depicted here. At the interim analysis, we had done in total 44 patients, 24 at the PA hospital, available data sets for analysis were 31. Now let's have a look at the initial results. You can see that the sensitivity was only 56, the specificity was 93, and this resulted in an accuracy of 74. But when we looked at the data, it was really striking that there is a difference between subjects who had the capsule in the stomach at the time of the endoscopy and at the time when the substrate was injected into the duodenum, as compared to subjects where the capsule had spontaneously emptied from the stomach into the duodenum while the patient essentially was waiting or wheeled into the procedure room. And in these subjects where the capsule already had emptied from the stomach, we had not a single subject who was positive on the Atomo capsule. Therefore, we under-record the prevalence of SIBO if there is a mismatch between the capsule entering the duodenum and the substrate. And here are the data in relation to the correlation between the aspirate and the breath testing. And in our cohort, the sensitivity was only 12% with a specificity of 82%. Now let's have a look at the sub-data set of subjects where the capsule was endoscopically pushed into the duodenum during the procedure. And the sensitivity for these subjects is 75%, with a specificity of 91% and an overall accuracy of 83%. Therefore, this highlights that at the time point of measurement, we need to have substrate into the duodenum. And this even might be important for other test modalities like the normal glucose breath test, where we may have a dissociation between ingestion of the substrate and the measurement. Our conclusion, the preliminary data clearly suggest that there is a good correlation of the Atomo capsule with culture results. And what is really important, that substrate is present in the smaller intestine at the time point of measurement. The next steps here are to increase our sample further, treat more patients, and consolidate the complete data set for analysis in relation to the thresholds. We need to better understand the link between Atomo results and symptom improvement after rifaximin treatment. And we will do further explorative analysis in relation to GBT and culture results. Here I would like to thank you for your attention and would also like to thank my team who was really engaged to get this study done. Thank you very much and have a good meeting.
Thanks to Gerard. Although he cannot hear him, but maybe you can give him our regards and our thanks when you see him next time.
Yes.
So you're going to answer the question.
I'll answer the questions.
Yeah. Fine.
Right, we have about 4 minutes before we'll conclude. So any burning questions on the gas capsule? Enrique?
I was intriguing about how was those curves in those patients positive for SIBO. I mean, the data was not shown, but does it increase? There is an increase in the hydrogen peak, or what is the?
Yes, there was a deviation from the smoothness that you would see if they didn't have the substrate. And the other thing that's very important is that it's not hydrogen necessarily, because CO2 in the proximal small bowel, respiration is the preferred way of, as long as there's some oxygen around, is the preferred way of getting their energy rather than fermentation. And so it's probably a mixture of them. But we've always been focused on hydrogen, which is probably what.
Well,
because we can measure it, that's right. And this is the first time we've been able to measure
there will
the CO2.
be a shift in the concentration on hydrogen and CO2 in some subsets of patients with SIBO and others with an increase of CO2 and decrease of hydrogen, I don't know.
Yes, and this is something which, but the breath tests that we have, and we haven't got all the data yet, but the breath tests were really didn't correlate at all. And none of them had the more than 1% hydrogen on the hydrogen sensor.
But you had a delay in measuring breath hydrogen because people probably got sedated endoscopy, or were they all awake and could go on with measuring breath hydrogen immediately after the procedure?
Yes, I mean, there was, they all did it immediately after, but I haven't seen the Brisbane data for the timing of that, but the Indian data was very clear. They're obviously pretty quick at doing all these procedures. That's right, Kyle?
They're not sedated.
They're not sedated in India, no. So what it has done, I think, is that it's alerted us that we've been kidding ourselves that it's all about hydrogen. It's more than that, and I think it's as a marker of what the microbial metabolic activity. But as Gerald said, this is really the first cut of data to try to pull this apart. And we know that bacterial overgrowth is very heterogeneous in terms of the bacteria, maybe fungi. I don't know if they produce hydrogen, but they produce carbon dioxide for sure. And so as this heterogeneity, we have to try to analyse all this with bigger numbers.
I mean, I guess the question will be normal values again. And you implied that you saw a quite distinct pattern in this group. Is that that will interest me to see whether that's quite so robust, because I'm assuming that also when we get really good at measuring these things, we're going to find that normal people aren't entirely sterile either in this area. In fact, we know they're not.
Yes,
but,
and we're looking for normal people who'd like to have an endoscopy and push the capsule down and have the glucose.
I think we can arrange that.
So Peter, I may have missed this, but in terms of the cutoff, was it 10 to the power of 3 for culture positive or 10 to the
power of 3?
10 to the power.
And if you did 10 to the power of 5, it didn't make any difference to the sensitivity and specificity.
So it was just a different cutoff in that case. Yeah, okay.
Different cutoff, you got the same
Proportions, yeah. Okay.
Proportions.
Well, if there are no... Oh, okay, last question, Jose.
There was a previous question about antibiotics, but do you expect any changes if people are taking probiotics?
They weren't taking probiotics.
No?
So they weren't allowed to have had probiotics.
But it will be kind of fun to prove Satish right that we're actually making our people unwell with probiotics.
I'd love to show that.
A lot of us would like that.
You're not allowed to call them probiotics in Europe, are you?
Of course. What am I allowed to call them, Jutta?
Which ones?
Functional food, maybe? I'm not quite sure. Well, that's fantastic.
All right. Well, thank you very much for attending. I'll have Mark have the final word and tell us what else is happening this evening.
Nothing's happening this evening. Satish